Thank you so much. Can everybody hear me okay? Okay, I do have quite a loud voice, but I am mic'd up. I normally walk around, for people that may have heard me speak before, I often walk around and you get a little bit more entertainment value for that, but I've been asked to try and stay put a little bit just for the sake of the video, so let's see how that goes. So thank you very much for that warm introduction, and yeah, it seems really funny when someone starts telling you all the things you have and haven't done. So, but actually I've been a clinical academic for ever since I qualified, from about a year after qualifying. So I did a foundation year, and then about a year after qualifying, and it was probably in my early days that I felt the most like a pure clinical academic, and we can come on to that, and I'm very happy to answer any questions or queries you may have about that. Just before I start, because I've got a lot of slides, and because I want to choose the focus quite carefully, can I check who we've got here so I can target it for you? So how many of you are students? Okay, that's nearly all of you. Are you all nurse students? Nursing students, okay. And then we've got a couple of others. So are you staff members? Yeah, okay, brilliant, good. Do we have anybody from the NHS side? Pure NHS side? Yeah, brilliant. Thank you very much. So could I just check from the NHS side, just because I just need to work out how much time to dedicate to it. There is a few slides about organisation support, which is some of the new aspects. Is that something you'd be quite interested in? Okay, that's fine. I think it's important, and I'll cover that as well. Okay, so some of it we will skip through quite quickly. Okay, I've chose quite an interesting title of whether it's Utopia or Dystopia, and I'm quite interested by that. And being a senior clinical academic myself, although I've driven this agenda for the last 10 years and really believe in it and advocate it, it is quite difficult. And these are not easy roles, but I think there's loads of benefits to doing them. So let's see how we get on with that, and we'll talk through some of those issues. So what do I want to talk about today? So I'm going to get us all on the same page, and I'm going to talk about what is a clinical academic, just make sure we all know what we're talking about. And then I'm going to talk a little bit about the benefits and to whom these roles might benefit. I'm going to talk a little bit in a chronological way, a little bit about where have we been. I'm not going to focus loads on that. I'm quite interested because I think it's been quite a journey already, and we've got quite a journey to go, but it can be quite interesting to know the history of where we are. And quite a lot about where are we going, what's this, and that's somewhere where you might be interested in. So what is there a future role that you may be interested in to do with being a clinical academic, particularly for those of you that are students. I'm going to focus quite a bit on what's new, and these are things that are very, very new, so most people in the room won't be aware of most of those. And then I'm going to just finish at the end a little bit around individual versus organisation, because that's one of the big contentious issues at the moment about where we are, and I'll explain that. And throughout the presentation, I'm going to use case studies. Everybody loves case studies because it kind of brings it all to life. And I don't want to be talking at you. So I'm going to try and use a few case studies to illustrate nursing, midwifery and AHP research activity and what a huge contribution that's made. Okay, so let's get all on the same page. So in terms of benefits first, let's just talk about research activity. So we know that research-intensive organisations do far better in terms of, or patients in those organisations do far better in terms of outcome and experience. Year on year, every single CQC report tells us that they have better quality of care in research-intensive organisations. So this needs to be a good thing, and it does in fact the quality and patient care that we offer and give. We know that there is a change in the NHS culture, and this has been a long history of 15 years where the finances are really driven, the financial change has driven the change. But actually, at a recent conference by the NIHR, which was their 10-year review, the NIHR made a bold statement which actually says that the research is now everyday practice. I'm not quite sure that's the reality. However, and I certainly don't think it's a reality for nursing, midwifery and AHPs. But I think there is an emergence and a change in that culture within the NHS for appreciating and valuing research activity. Some of that could be driven by finances, but hopefully most of it is driven by benefit to particular patients, but also to staff. We know that high quality evidence will help inform good clinical decision making. And I'm going to suggest that the role of the clinical academic is ideally placed to facilitate the adoption and the spread of best practice, innovation, research, evidence, and particularly using new technologies. I don't think anybody would disagree with any of that. Now, I don't expect you to see all of the little ones, the little boxes, the little circles around this, and I'm just going to highlight 3. But actually, there are huge benefits to the clinical academic role. And the ones that I'd like to actually talk about is we know that recruitment and retention is a huge issue. It's fantastic for use because everybody wants you. And actually the bargaining power is actually very much going to be with the students and the qualified staff. And I think that's a good place to be. But actually there is something around research and evidence and particular investment in staff in terms of staff feeling valued and investing in their development. Actually, I think will improve recruitment and retention. So would you want to go and work in an organisation where you felt they really valued evidence and research and would support your development to enhance your skills? Are you more likely to go and work in that type of, or want to work in that type, or stay in that type of environment? Yes, I suspect you will. So I think there is a role in terms of the clinical academics, in terms of the current crisis that we've got, in terms of recruitment and retention. I also think there is something around reputation to organisations in the fact that I think medical research has always been around for a long time and people know that there are new drugs, new technologies, new treatment options, but actually there's equally as many care options and experience options that we need to go through. And we know that 20% of what we do currently is based on evidence. The other 80% is historical practice and lots of other things that we do. So there are still lots and lots to do, to question and to challenge, to do with the care agenda, as well as new drugs and treatments and other medical-led type of research. And then finally, what we hope to do at the end is the patients need to stay at the centre of all that we do. And we must never forget that. And although this talk is predominantly around the development opportunities for health professionals, we mustn't forget that all of us are here for the same thing. And it's about improving the care and access for patients. And I think all patients, regardless of their condition, acute or chronic, should have access to new technologies, new treatment options to make sure they're getting the best care available. So actually, and we mustn't forget that they're actually the centre of everything we want to do. So that's kind of the 3 key things that I want to pull off there. And this is just one of the case studies that I'm going to start with. So Jackie Pareto is a nurse consultant at Southampton. And this is one person, one study. And I'm going to say this repeatedly during this session. But actually, Jackie undertook a PhD, and she did it about reducing the catheterisation rate and the incidence of CORTI. And she found huge difference. Not only did she find a massive reduction in the catheter rate, in the infection rate, she standardised documentation, she developed a new evidence-based policy, and actually demonstrated that she could make a saving of about £130,000 per year for her organisation. Absolutely huge. In addition to that, there were some others in changing the type of catheter that was being used. So actually, that's one person and one study. What collectively could we do to change it, to change things, is immense. It's really powerful and really important. I am going to give you a little bit of chronologic background, and I make no apologies for this. And to illustrate this, I just want to use a quote from Alice in Wonderland. That one day Alice came to the fork in the road and saw a Cheshire cat in a tree. "Which road do I take?" she asked. His response was a question. "Where do you want to go?" "I don't know," Alice answered. "Then," said the cat, "it doesn't matter." So therefore, actually our travel of direction of where we've been, but particularly more where we're going, is really important, because how will we ever know what the journey is or how we've got there? I'll leave you with that thought for a sec. I just want for a second to focus a little bit on lessons learned from the medical profession. And interestingly enough, we've had, over the last 5-7 years, we've had lots of conversation with medical leads who actually started off the medical careers, who developed what is called the Walport Report, or the Walport Pathway. And this is a guy called Mark Walport who's in that picture there. And they have what we in nursing, midwifery and AHPs would perceive as a well-developed, accessible, clinical academic pathway that takes them right from undergraduate right through to professor senior lecturer level. And we often are jealous around that. But actually, interestingly enough, it's not got a long history. The medical clinical academic pathway only came into place in 2005. That's not very long ago, actually. And there is a number of very successful things they've done. They did undertake a review 10 years later, which was last year. And that's interesting what they produced in that report, in that they turned around and said the greatest achievements have been the recruitment of gifted young doctors into integrated academic training programs that support progression to careers in clinical academic medicine. That's quite interesting. That's quite a bold statement to make just 10 years after a pathway had been set up. But they still said there's lessons to learn going forward, and their message to trainees was that careers cannot be planned, and these are things we've got to learn. And the importance of mentorship is particularly important, especially as the academics are not taking a path that's very well trodden. Actually, for nursing, midwifery and AHPs, that's even more the case, and that's even more complex and difficult for us. But they've managed to do it in a 10-year period, and they now put through 250 medical ACF trainees every year. And that's very impressive in terms of changing that research culture across the medical profession. And if we want to do something, we need to do something similar. What is quite interesting is when I spoke to the peoples that actually initiated the initiative around the Walport Report and medical clinical academic pathways, I asked them about, did they have to put a case of the benefits of why they had to do it, because we're finding we're having to do that in nursing, midwifery and HPs, and they didn't. And they said it was just automatically assumed that a pathway would be of benefit to patients and to care, and that this would be worth investing in and doing, and that they didn't need to show and prove the outcomes and the impact of doing so. Unfortunately, that doesn't seem to be the same case for us in nursing, midwifery and HPs, and I get very cross about that aspect. This may be familiar to you, so this is a bit around our history in nursing, midwifery and AHPs. So those of you that are quite young and students will probably have never heard of the Finch Report. Is that correct? Yeah, you've not heard of it. Okay, so this is just a tiny bit of history. I'm going to flick through it. But actually the Finch Report was published in 2007. And that was the first time that I can say that from an England-wide perspective that we started to recognise that there was a need for nursing, midwifery and AHPs in terms of research activity. And the results of the Finch Report actually suggested that we should have dedicated funding, and that because we're in such an early stage of our career and pathway, that we needed dedicated funding where we didn't have to compete with our medical colleagues, and that we could do capacity building through that. And that was one of the main outcomes and intents around the Finch Report. And then about 6 years ago, we started a group, and I'm honoured to actually chair that group and have done since it started. And we've done a large amount of work. And what we've done is been working with chief nurses across the UK. So that includes Wales, Scotland and Ireland, as well as England. And working with and partnering with lots and lots of all the important organisations that we need to. Do we all understand what a clinical academic is? Would you know what one was? Is it intuitive? Anybody want to have a guess? The slide helps you. What do you think? Might be. Maybe involved in teaching. Maybe involved in teaching, correct, yeah. Okay, that's quite interesting. So that's about clinical experience and roles informing research, I think is what you're saying there. So yeah, very important. That actually is a role of a clinical, and that helps the synergy, but that it doesn't particularly describe what a clinical academic is, but good attempt though, good attempt. So a clinical academic in its purest sense is a person that simultaneously undertakes both activities. Now the difficulty with that terminology is that what do we mean by clinical? And there's a big argument, a big debate that's going around. Does that mean you have to have direct patient contact? Or can someone be classed as a clinical academic if they have indirect contact and therefore influence and grow other people who indirectly then make an impact on patient care? So those debates are still going around and still being had. And in terms of the academic side, you're quite right. It could be a teaching focused, but in this context, I'm talking about a research focused one. However, all of the principles that we talk about could equally apply to an education-focused clinical academic. Okay, but for this instance, I am just talking about research. And interesting when I talk about the title on the slide, which is about Utopia and Dystopia, and dystopia being an imagined place or state in which everything is unpleasant or bad. You're all going to say that's the current climate of where we are. I hope you're not going to say that. But there are challenges, without a doubt. But actually, some people might say the clinical academics is an ideal role, because if you can develop yourself and continue to develop, change things, grow, as well as continue to practice and do what you love and and continue to do the things what brought you into nursing in the first instance, then some people might say the role of a clinical academic is an ideal post. It's perfect. So some people may say that's a utopia role. And they might say that's an imagined place or state of things in which everything is perfect. Can I say, as a senior clinical academic, I would say that it's not quite perfect. And I think we've got some way to go. This is a career pathway, and this is some of the work that we've done as part of that large group that I mentioned just before. And this is now, we do have a defined and agreed clinical pathway that actually has been written into policy, national policy. In a simple version, okay, this is what that shows. So it shows us that we need to progress and think about and consider our clinical aspects, our academic endeavours, and our leadership, because there's no point in having research or evidence, knowledge and skills if you don't have the aptitude or the skills to be able to transform and to put that into place. So actually leadership is equally as important as is the knowledge for the other two aspects. And that as someone progresses, that they will gradually increase. And that someone may move from an early career to mid-career to senior career. And at early career you would focus on developing self, mid-career developing others, and at senior career working through an organisation level. This is another case study, because this is why I'm saying about why we've got to demonstrate impact. So most people that I try and speak to, that I try and say, let's try and get a slide and capture what it is you did and what's the impact you made. So this is Karen Marshall, who's a consultant nurse at Newcastle upon Tyne, who was a consultant nurse in respiratory nursing. And she was really concerned about her main area of specialty was COPD. I'm sure people know what that is, so that's okay. And she was particularly concerned about the number of patients that get very anxious. As we know, COPD is a progressive disease where people get increasingly breathless. And it would be quite normal to think that because you're having difficulty breathing, which is getting worse, that actually someone might become more anxious about knowing that they can't breathe, and therefore how do they manage activities or just to actually walk around. And she was quite concerned over that. So she felt that she found out that 60% of COPD patients in Newcastle got anxious about their breathing, and at 45% felt low or depressed directly as a result of that. So Karen came up with an idea that why don't we look at physical-based CBT to see if we could change the way they think and they manage that breathlessness, knowing and accepting that it's a progressive disease. So Karen undertook a randomised control trial where she gave half of the patients a leaflet, so they got something, and then she gave half of the patients CBT plus a leaflet, and then followed them up to see if it actually reduced the amount of anxiety, depression and hospital admissions that patients had. Because what she found is that a lot of them were being admitted because of their anxiety over their breathlessness rather than the condition itself. And Karen has found immense. The study has just finished, and it's just been submitted to the Lancet. So actually a really good, really good, powerful study that would equate or be the same as any of our medical colleagues in equally as weighted and powerful journal, such as the Lancet. So, you know, there are work that is really important that nurses are and can do. This is another one from my midwifery side of things, and this is just to say that everything doesn't have to be very big, and that this is Carly Allen, who was a research midwife who undertook a master's, and she wanted to explore what we meant. People band around the term well-being all the time, and we wanted to know what was the context of well-being in relationship to perinatal mental health. And she did a really nice study which tried to understand it much more better about what well-being means within a maternal context. So not something that's going to change the world or get into the Lancet, but actually a really important study that's something that we say all the time, that actually, but really do we fully understand what we mean by that or what the impact is to women. Since following the Finch report, in 2012, there was another review, and they recommended 5 recommendations in 2012. So these included a national review to continue to secure and sustain that funding stream that I was mentioning before, to increase the synergy between national and local training schemes, and to accelerate support arrangements, and also to develop a national group. There's loads. One of the things that the big group has been very successful at, I can mention at least 10, if not 12, national policy documents where it advocates the role of the clinical academic in terms of increasing research activity to improve care and experience. So this is great, and it's been a great thing, and cultural shifts are the hardest thing to do, but to actually have got into a load of national policy documents about the importance of setting up and doing that is great actually for nurse and midwifery. In the new nursing document, the new nursing strategy that was just released in March, then actually very much the second statement or recommendation is about closing the care and quality gap, and highlights the need for us to ensure that we are delivering and thinking about evidence-based care. So actually it's not going away, which is great. This is the new training scheme, which you may or may not be aware of. And I'm going to break this up into some more components, but this is quite a nice visual slide, just to say that there is secured, dedicated funding for nursing midwives and AHPs, which goes from now pre-master's level right up into professor level. And I'm going to break that up into some components for you. And this might be something that you as students may be interested and want to access at a later date. However, what do we know out of that funding that has been put aside, which was nearly 50 million? What we do know is that the number of applicants they were of poor quality that we could not, the NIHR could not spend the allocated money that was allocated to this particular dedicated funding source because of the poor quality of applications that are coming in, which is really worrying, and they've repeatedly questioned whether or not they should stop that funding source. But at the moment it's our only funding source, and it's very generous in the fact that it gives you full salary, all your fees and all your research costs. It's the only scheme that does that, and it's certainly comparable to all of the medical schemes. But actually there's been so much concern about the quality at every level, right from the master. So I'll come on to a little bit about what we've done about that and what's changed. We have got a new definition which was published in February of this year, and this is a brilliant, really brilliant, easy to read little brochure. So if you think students should understand it completely, if you think you might be interested in the role in developing and working towards to be a clinical academic, I would highly recommend this little document to you. It's easy to access and to download. It's really nice, and it's built on for individuals that are interested to try and get you interested, enthused and understand what they do and what benefits they can have. It's a brilliant little document. And that was just published in February of this year, and it includes a really nice new definition of what a clinical academic is, which I really like. I'm not going to go through that. What else is new? So we know when we've done some assessments around the number of clinical academics that we've got, we know that 5% of our medical colleagues are what you would class as a clinical academic at a senior level. That's at professor level or senior lecturer level. Yeah, in nursing midwifery, I should have asked you this as a question really, but the answer's up on the slide, so I won't go for that. But actually in nursing midwifery and AHPs, ours is 0.01%. It's tiny of our workforce that is a clinical academic. So we've put a campaign together or a target together of where we want to try and increase it to 1%, which is tiny, 1% by 2030. Some people say that's aspirational, some people say that's not aspirational enough, but actually it's a target and allows us to try and head somewhere. What is really worrying is in 2015 when we did some assessment looking at clinical professors, which is a similar role to myself, that we had very few that were in nursing, tiny in midwifery, and in fact now I'm the only one that represents midwifery, and not very many in AHP at all. So it's really interesting that the money is there, we think the role's a really good important role, but actually they're not really in place. And why is that? We need to try and understand that in much more detail. The traditional route of having a training pathway, a clinical academic training pathway, all of you will be familiar with this, is that you go from your degree to your master's to your doctorate to postdoctorate to professor level. Because of what I said about not using that funding and getting quite poor quality applications, some new points have been inserted into that pathway. And this includes pre-registration, so this includes all of you at your levels. So there's a huge emphasis around increasing knowledge and understanding with pre-registration in terms of giving you opportunities to go to like a research facility during one of your placements, to you having more input about research so that when you finish your degree you're competent and different, because what we recognise from that slide, you probably didn't get to realise it because I flashed it over, but actually the AHPs do much better than nursing or midwives do. You may have spotted that on that other slide. And in fact that's because we feel that they come out better prepared. So actually we needed to start with the pre-registration ones, because if we're not bringing you out and you're not adequately prepared to start to go on this route, we're never going to be able to grow all these clinical academics that we really need to. So pre-registration has changed, yeah?
Is that maybe tied up with the sort of research that AHPs do as well?
Yeah, well, I've got two reasons why I think that might be actually. Good question, thank you. I think there's two reasons, and this I have been quoted on these, fortunately or not, but that's fine. And my two reasons, I think, is one, because I think they come out better, a better stage, better qualified, with more knowledge, or they did, compared to traditional nursing and midwifery outcomes. And my other reason, I think it's the autonomousness of their role. And I think that's the other reason why. So it was their role that it's a bit like the specialist nurse or nurse consultants. If you've got a very defined role that's specialised with a caseload, with expert knowledge where you can change it, and not like the bedside, wardside nurses, which have a very generic, and I don't mean that in a disrespectful way, but they have a very generic core role as opposed to a specialist role. So I think it's about the autonomous nature of the role. That's where I think it's from. So that's new, and you need to be aware of that, and you need to talk to your colleagues and Oxford Brookes and your other people around about opportunities. And the NIH are particularly interested in this, and I've done a lot of movement around us more preparing students much more adequately for opportunities in research and for the roles of clinical academics. So it's a big push at the moment, and I think this is a great thing. The second thing is, instead of just starting at a master's level, we've now got another level which is actually pre-masters, which people call different things, but actually there seems to be a generic name that they're called interns. And these now are being nationally funded. And this is an opportunity when you go between your degree before your master's, before you enrol on a master's. So it's a 1-year programme, fully funded, as in you get so many days, it's usually 10 to 15 days paid, which your organisation get back. And then you get a development programme, and extra, usually access to a module, and then peer support and external speakers to help promote and encourage you and to get you ready to submit a good quality master's application so that you can be competitive for one of these national awards. And then we've got the masters, which is I'll come on to in a minute. And then we've got another one, because we know that there's a gap. Before you went straight on between a master's and a PhD. But now we recognise that people need dedicated time and support and mentorship to be able to develop that high quality application that's needed. So now we've developed a fully funded Masters to Doctorate Bridge programme, and these are now just evolving throughout the UK. There's not many centres that do it at the moment, and quite a few have got informal support, finance. Birmingham's got a large one, and is one of the big pilot sites. That's because it was my idea, and I felt that was a big need in terms of where we're going. So I'm very proud of the fact that kind of the Masters to Doctorate Bridge is now being adopted nationally, which is great. And then go forward with the other senior roles. The other thing that's really good that I want to mention to you is, if you are interested, and even if you're not, you should be aware, but there's a really nice, they call it a magazine, newsletter, I think they call it, but actually it's much more than that, and they're up to their 3rd edition, and they're really good. And I've only just recently become aware of it myself, that there's been published, so I'm not sure how many of you will be aware of it, but I've put the hyperlink there for you to access it. But they're brilliant, and the last one that was just released about 10 days ago talks all about work-life balance and all the issues that we've got with being a clinical academic at the moment and doing equivalent of 2 full-time jobs. Health Education England are also developing an interactive virtual guide to encourage, support and enthuse people that want to be a clinical academic. And they're apparently going to release what they call the light version in November, end of November. And then it'll come out, the full version will come out the beginning part of next year. So a lot of emphasis from the individual's point of view about how we can try and increase your understanding of the role, support you, enthuse you, mentor you, give you the best opportunities that are available to do so, to become a clinical academic. I'm just going to focus, well, I've kind of mentioned these anyway, so this is the pre-registration. I'm just going to take you a little bit through that pathway. So in terms of pre-registration, which is what most of you will probably be quite interested in because of the audience. Often, like we say, clinical research placements to do with clinical research teams. So if there's a particular area that you know already that you might want to go into, adult respiratory or paediatrics, palliative care, then actually there's probably a research team that is around that topic area. And even as a student, there is value in you starting to link up and get some exposure with a research team based in a particular specialty area that you might be interested in. And that's kind of, we're going to be doing it much earlier on rather than wait until later, and start to get, the research team should then start to engage you in some of that work that's taking place. You can start to get your name on some papers, you can start to get some exposure about how to develop a question, how to answer the question, what to do with data, etc., etc. The other thing is, there is a number of, there's about 16 now clinical research facilities, which are physical facilities where clinical research takes place. And there are a number of these, I'm trying to think if you've got one in Oxford actually, have you? Do you have a clinical research facility?
Yes.
Yeah. Do any of your students go? Starting to, okay, so exactly. It may not, it's a lot, there isn't many, there's about 14. You're going off for a day? Yeah, it's quite new. Yeah, it is quite new about having research placements either with a team or with a research facility, and it can be a little bit contentious because people think, "Wow!" But we want you to understand it early on. We want you to have the skills and the interest and we don't want you to go into the clinical practice and get so embedded into that culture that you lose that inquiring mind. We don't want that. We want you to continue with that same inquiring mind that you have during your training. And that's important. We don't want a gap between that. Okay, we don't feel you need to consolidate. You can continue that inquiry and that journey onwards. Okay, and a little bit around the internships that are funded by HEE at the moment, and they're worth it. So if you enjoy study and you think you might enjoy research, I know it's only a small number of people that do, but if you think it is something you're interested in, then actually you might want to start thinking about how could you access one of those intern programs, which bridges between the degree and the masters. These are the master's programs. These are the ones that I was mentioning that are fully funded. So you get all of your salary, you get your full fees paid, and all of your research costs. And these are masters, and there's 10 centres across the UK. So your nearest one is, where's your nearest one? Southampton? Coventry? Coventry is fairly competitive because we all go into that one from Birmingham too. But yeah, so I mean, there's a few around for you. So you've got Coventry, and then you've got some around London, and you've got Southampton. And they're definitely worthwhile doing. And if you go, I'll put the web link on there, and it tells you on there how to apply and how to contact. And they often take an expressions list. So even if it's not open, even if you're interested for 12 months' time or 24 months' time, then, and we are looking for younger, without me being ageist and getting in trouble, but we are looking for younger people that want to do it and develop it, okay, and that want to move into these roles early on, so we can support you. Okay, and I'm going to talk a little bit about doctorate. Now, this is quite a bit I'm going to speed on to this. Is any of you particularly interested in applying for a PhD program? Or you're all quite, you are at some point actually. Okay, right, I won't skip too much over it then. Okay, right, so let me share with you a little bit. So I'm going to wear a slightly different hat during this because I also sit on the NIHR doctoral panel. So do you remember when we looked at that pathway and we talked about masters and then PhD? So the PhD program, I sit on that panel and we're interviewing for this year next week. So I've got some insider information from sitting on that panel, as well as supporting a number of other people that have been successful. So let me just share a little bit of that with you. So what we're very clear about is that it focuses around three things. Okay, it focuses about the person, the environment, and the project. Interestingly enough, it's in that order. We are more interested in the person and their ability to become what we want is a research leader than we are of the environment and the project. The second most important thing is the environment and the organisations that are going to support you. Because there's no point if you've got all the passion and enthusiasm and you're not in a great environment, either from an NHS side or from a university side. So they need to have a good understanding of what a clinical academic is within both of those environments and be able to demonstrate and evidence that so that they can support you in your application and that they can get the assurance that your organisations know exactly what they're talking about and how to support you. And the third and most important one is the project, which is quite interesting. And the project, if there are things that are repairable, you still will get the funding. So focusing on your own portfolio and your own, and I'm going to go through some tick boxes that you need to tick, about you as a person is more important than getting the project right. You do need a good project, an important project that can be delivered, of course, but actually it's not the most important thing, okay? Any of you surprised by that? A little bit. Okay. That's because it's a fellowship, and fellowships are often about investing, well they are, they're about investing in the person and about developing the person in a supportive environment and help them develop important questions. But the focus is definitely on the development of the person rather than the project. So what I'm going to say here, these are the things that you need to evidence at PhD level if you want to go for one of these gold standard NIHR awards. I've been fairly lucky and had 7 successes. Not person, well, I was one myself a long time ago, but 7 people that I've supported through to get it. I'm actually, not just because I sit on the panel, but I was aware of it before then, that actually I'm very clear what it is they're looking for and what they need. And I think they're not as transparent about that as maybe we could be, hence me telling you this information now. But they need to demonstrate leadership for the reasons that I mentioned before. So being able to demonstrate that you've done either a leadership module or you've been exposed to it. So not just that you're a clinical leader in the field. It needs to be evidence that you've gone through some sort of training, some sort of leadership training. They want to show that you've got the confidence to be able to deliver change and to actually to have the stamina and the confidence and the tenacity to continue and to do it. Doing a PhD can be quite difficult. They want to look for a grant profile, so that's quite hard. My first grant that I got, which was about 2 years after I qualified, was for £250 from a trustees. I remember it. I remember it really well. I was delighted. My last one was 1.7 million. But it doesn't jump from that to that very quickly, okay? So it's taken me lots and lots of years to do that. And applying for money is that for 250, 500, 1,000, 5,000 are all very, very valued. And at an early stage of your career, even as a student, you can apply for a load of these things. And if you want to be classed as someone that is going places and getting there, you need to show how you're different from somebody else. And why you? Why should they fund you? Okay, and this can start, and it doesn't have to start later. So applying as a student to do a small project and get 250 to do a very small audit or a small project is really valuable, and it'll start to go onto your profile. And you never know, you could grow and maybe become a clinical professor one day and get a grant of 1.7 million. But it's a hard slog. It's took me probably 25 years to get to those, to bridge those two. But they do need to see, even at doctorate level, they need to show that you've got some mini grants, okay? And you can't afford not to tick that box. So you need help and support of other people to be able to support you and to apply and get the right questions and do some mini projects. Publications, they want you to have published. So for most of you now, even with your degree level, then what we're often asking you to do, and I don't know if they've changed at Oxford Brookes, but a lot of universities are changing, in that your dissertation is now a paper submission or a preparation for a paper. Have you changed to that?
One of the options.
Okay, so I think we're moving towards that, and that's a really good idea. So that means that even at the end of your training, you've got enough evidence and a good quality enough information to be able to submit for a publication, and that's great. That'll go on your record, and then you need to continue to build that. Okay, it's probably one of our weakest points in nurses, midwifery and AHPs is publications for most people. Esteem factors. So there's a student nurse award. I'm just because majority of your students, I'm aiming quite a lot of the conversation at student nurses, but there's a student nurse award. If you got one of those and was allocated that, in 5-10 years that will still hold its weight. So there is things that you can do now that will add to your profile, that's going to grow it, that's going to make you different from the next person in the next 5 to 6 years, and they're all worth doing. Your career plan, you need to know what a clinical academic is. We all use those terms. Know what a clinical academic is, and now have a rough idea how you're going to get from A to B, or where it is you want to be. And then for a lot of them, if you've already got on one of the NIHR schemes, early schemes, you stand a much better chance of getting on a later scheme. So if you get one of the NIHR internships, you're already starting on the road. And you're more likely to get one of the NIHR masters, and if you get an NIHR masters, you're more likely to get an NIHR doctorate. So you're just starting off, so even early on, it's worth all that effort. Okay. In terms of the environment itself, so I want to talk a little bit about the environment. So you need the environment needs a strong research profile, evidence of working together. We actually ask during the interview how many times you've met, who did you meet, did they have time, how long, what was said, how did you deal with any conflict, and they go into that much level of detail. Who your supervisory team is, you want someone off your own professional group, and need to make sure that it's not considered to be a medical-led project and that you're just helping out or doing the work, and they can see through that within seconds. And investment and understanding of the clinical academic roles, again, important. About the project, 80% of those that are funded, this is at PhD level, contain a systematic review, development of an intervention, and a pilot randomised control trial. So there is a set format for NIHR. That doesn't mean to say qualitative studies and other type of studies don't get funded. It's just harder to actually convince the panel that that's a travel of direction. I'm just going to skip over it. Now, you'll have a copy of all of these slides later, but I'm skipping over a couple of them so I can focus on the important bits. When I mentioned about one of the new things, which was the Masters to Doctorate Bridge, one of the best ways to illustrate how that works is to use a case study. So here's another one for you. So this is Lisa Shepherd. She's at Birmingham. She's an endocrinology, there's a spelling error there, an endocrinology clinical nurse specialist. And she's got one of those Masters to Doctorate Bridge awards. And I've been mentoring Lisa for the last 18 months. She's one of my mentees. And we've been working with her from a person perspective. So she's got 3 publications already in that 18 months. She's applied for, well, it was 4 then, she's now applied for 5. She's just submitted another one for all small amounts. Some of them has been successful, some haven't. We've encouraged and supported her to get national and international roles so that fits on her profile, and encouraged her to do a leadership module so that she can tick that box. In terms of the environment, I meet with her other 2 medical colleagues who are also on her supervisory team, and we've met monthly, and we're still meeting to help support her and define her and give her lots of time and support, both in terms of her development and in terms of the project itself. And then in terms of the project itself, we're helping her formulate what that project looks like, what's an important question, what's feasible to do, how could she do it. She's in endocrinology, but she's particularly interested in Addison's disease and about avoiding a crisis, which often occurs, as you may know, in young people and can be life-threatening. But actually a great example. I meet Lisa very frequently. And it's been great to actually see her through that journey between her masters. And she'd have thought she was ready just to go straight in and apply for a PhD application. But actually, there's so many boxes you have to tick for us to have the assurance that she'll stand a good chance. We needed to touch, it took us at least 18 months. She's actually probably going to be a very strong candidate for next May when it comes out again. And that's because we already know she's going to tick these boxes. But that's not without hard work from her point of view or other people around her. The panel itself, I'm not going to talk to you loads about this, but it's a very, very tough. We do mock interviews for people that are going for it. We've got the interviews next week. There's 30 people, all professors. I kept wondering why they'd never invited me to that panel when I'd been on this agenda for so long, and I suddenly realised it's because I wasn't a professor. So as soon as I got a professor role 18 months ago, I got my invitation to join the panel. And when I got there, I realised it's because everybody else is a professor too. There isn't one person that isn't a professor on there. And you have 30 professors asking questions. I mean, it's really tough. And they do give you a hard time. So these are not something that's easy to get. So actually having support and mock interviews is really important. I don't want to make it unattainable for you because it is attainable. It's just hard. This is a study that I did during my PhD, so I just want to talk a little bit about impact and about where we might go. So this study was on a randomised controlled trial about the role of a specialist midwife or multiples. So that's parents and mothers particularly that are expecting twin infants as opposed to a singleton infant. And the output of that, so that was conducted quite a long time ago, it was published, but actually it changed NICE guidance. It got in the most common book that parents that are expecting twins buy. There was a video. The role was implemented across the UK. And this, again, one project, and a huge impact. And just think what we could do collectively if these individual projects can make so much difference. I'm going to skip over that, and I'm going to skip over that a sec because I want to, I just want to come down to something about organisation. Whoops, let me go into this one. So I've focused a lot of that time on what is if for individuals. So all about how we can encourage, enthuse, support you, and what we know now about the high quality applications that need to come in. But all of that is pointless unless we are valued and we can encourage it within organisations to understand, want it, value it, and will equally to support you either during those transitional bits or when you go back into clinical practice. Okay, so this is a huge gap in terms of where we are. And in terms of NHS organisations really appreciating MMAP research activity, we've come quite a long way, but not far enough. And what we need to do is to make sure that people that are making so much effort and the funding's there and people want to do it and the support's there for them, but we want to make sure that it's truly embedded within the NHS. And actually, so that's where some of the gaps were, and some of this was just in understanding. Some of the chief nurses didn't particularly understand the benefits that one of these type of roles could do, or more of them. So what we've developed is what's called a virtual organisation guide, and this has been launched on the 14th of November, so it's very new. runs through the AUKUH group, which is that group that I mentioned to you early on in the slides. And it's going to be a virtual toolkit. We're just in that very last version. It's being digitalised at the moment as we speak. And it's a virtual guide, and it's mainly aimed at senior leads in organisations to support, encourage, enthuse and support people that want to be a clinical academic within an NHS environment. It's got a number of elements to it on this interactive toolkit, and we talk about an organisation being ready, having the right culture. We talk about how do you identify, enthuse and support those that want to be a clinical academic at all the different levels, and how can you demonstrate impact, what difference does it make to the service, to patients, to the individual. And moving forward, we're creating a network of all of these nominated leads, and there's 65 organisations that are interested in developing this. So this is why I know it's coming, and I think within the next decade we will see a huge difference where the clinical academic role is well embedded. How might it work? Well, we see it as a kind of 50-50 model, so that someone could stay in clinical practice and 50% of their time would be doing academic, in this instance research activity, and 50% of it would be doing clinical activity. Skip over that one. And this is in terms of, there's a whole section in this toolkit. Sorry, we called it a toolkit for ages. It's actually been released as an organisation guide, but I keep referring back to toolkit, so I apologise for that. So in the organisation guide, there's a whole section about how can the organisation make sure it's ready, that it's got engagement at executive level in the board. There's a number of models which will help us develop and support. One of those is a model that I developed, which is ICE, which is improving care through evidence. But there's a number of other models. That's not the only one that's available. And we know that different organisations will want to focus on different things. So this might be where, if you're interested in being a clinical academic, and there is an opportunity in more than one clinical environment, you might want to ask them where their priorities are. Where's their strategy document which says where they're going to invest and support? And it might be at master's level, it might be at doctorate level. So it might be that a different organisation is focusing on a slightly different aspect that's more fitting to where you want to be and go. We've done a lot of work around making it very practical for organisations to work out how to identify high flyers, people that, with the 3 that wanted to do a PhD, are you all students? Yeah, it's really interesting. So on your clinical side, I bet they haven't got a clue that you might want to do a PhD at some point. So part of this document is around identifying high flyers. So those that have got the ability and want to go forward in this sort of capacity and to get a master's and a doctorate at a later date. And then how do we support and engage you and actively pursue and raise your clinical expertise at the same time as raising your academic. And then quite a lot around impact. I get quite disappointed over the fact that in nursing, midwifery and AHPs we've got to continue to demonstrate impact of what we do to secure our funding and to secure these roles. However, that's where we are and that's where it is, so we have to do this. That's another study regarding PTSD, but I'm just going to leave that. You've got a copy of that for you, and another one around sleep in hospitals, which again was a really important, simple study about improving patients' sleep in an ITU and then the ward environment, because that was equally as noisy. And this was a very simple study about improving breastfeeding in terms of where the baby's, the physical attributes of a baby's mouth and the nipple is on a breastfeeding to improve breastfeeding rates. Very simple but very effective study. So what's my take-home messages for you after all of those millions of slides? So my take-home messages are 3. So we know that best things you can retain are in 3s. So it's got 3 points for you. So research is important and valuable. Hopefully I don't need to convince you of that. That nursing, midwives and AHPs and MAPs can and do make an important contribution. Hopefully I've demonstrated that a little bit to you. And that the goal across the UK should be that we can identify and maximise individuals' potential within an environment that is supportive, engaging and values their research. And I think that's where we are and that's where we're moving. And I think it's a golden opportunity for where we are and where we're going. Thank you very much.